Mhm. Good day. I trust we can all hear me. Welcome. If we are tuning in right now and we can hear me, please do let me know that you can hear me. I would appreciate that. Sorry, there was an issue with the initial link, but we are live right now. We are very, very live. Well done. Well, welcome to point of care ultrasound in the assessment of ectopic pregnancy webinar. This webinar is designed to strengthen and consolidate clinical practice, more excellent clinical practice at the bedside. Quite a lot of facilities have these ultrasound machines and are not able to help these emergencies. That is why we are, doing this lecture for us today. And in this lecture, I'm going to help that health practitioner know what to do when an ectopic pregnancy is clinically suspected, before thinking of all other forms of escalations, thereby preventing wastage of time in the management. Because in this situation, the clock is ticking. The clock is ticking. And so for that very reason, I'm going to be sharing this with you today. So we're welcome. It's always a pleasure bringing these lectures to us. 1 minute, please. But if we can hear me, please, I would like those that are on the chat box, just let me have your responses on the chat box. The chat is live, so you can just let me know. Oh, fantastic. Okay, good. Someone can hear me, basically. So I believe the others can as well, basically. Yeah, so we're welcome to this session. Oops, sorry. We're welcome to this session. Oh, sorry, there was an error in this particular um, 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 graphic design. It's supposed to be ectopic pregnancy. Nevertheless, the title says it all. Apologies for that. So, welcome on board. Let's quickly move. So, in discussing how to properly manage ectopic pregnancies with the ultrasound to support clinical decisions, I will be talking under the following outlines. We'll be talking about an introduction, epidemiology, the risk factors, clinical presentations, the relationship between serum beta HCG and gestation, that is normal gestation and ectopic gestation. And then we will now talk about the ultrasound features. And then we will just summarize, and then that will be all. So you can see this lecture is not just only going to talk about the ultrasound features. I'm also keen on making sure that our management is whole, even by knowing how to correlate laboratory investigations with ultrasound findings in order to help clinical decision making. And that's why we will be speaking on such kind of concepts as serum beta HCG and ectopic gestation. It's going to be a very fantastic presentation, and I look forward to a good time. Okay, so please, before we begin, let me just see and just follow up and see what's going on. Okay. All right. So I can see that we can hear me. More people are hearing me, which is very, very fine. I am glad about that. So let's talk ectopics. Okay, let's do this. All right. So, ectopic pregnancy, brief introduction. Ectopic pregnancy is the implantation of a fertilized ovum outside the uterine cavity. So you have the egg and the sperm, they come together within 24 hours. You have is what's it called, the zygote formed. And then normally that ideally should insert into the uterine cavity. But then that should ideally implant in the uterine cavity. But we have this particular gestation developing what's it called gestation, implanting elsewhere. In this case, as you can see here in the fallopian tubes, except for the endometrial cavity. It is an emergency. It must be dealt with utmost priority. When it comes to prevalence in the country we're in, Nigeria, this is an a not so recent prevalence, but nevertheless, it still applies in some certain conditions. It's not so old. It accounts for about 1.4 to 3.8% of what's it called of all pregnancies, and that's higher than the global average. The US prevalence rates are about 1 to 2%. And in all 100% of cases that present with ectopic pregnancy, there is usually a very high mortality rate, 10.4 to 23.1. This is not necessarily because the condition in itself is a sorry case. Rather, some factors like limited access to healthcare and delayed diagnosis increase mortality. That is why we're trying to solve issues like delayed diagnosis with this kind of webinar. We believe that we can do this, and many doctors, many people, many health practitioners, those in the PHCs and all of that, once they see or know how to assess by this simple knowledge that will be disseminated, then they will be able to make an assessment quickly and prevent delayed diagnosis. Prevent delayed diagnosis. Prevent delayed diagnosis. Is that okay? Okay, very good. Sorry, one brief minute, but I trust that so far so good. We are following everything I am talking about when it comes to this particular concept. Good. So, um, yeah, let's continue. Okay, let's continue. So, when it comes to ectopic gestational sites, when it comes to ectopic gestational sites, we have some few sites that they occur where it implants. Where it implants, sorry. A high percentage of all implantation takes place in the fallopian tubes. Yeah, a high percentage takes place in the fallopian tube. A fewer percentage would insert into the ovaries to form ovarian ectopics. What's it called? A similar percentage, less than 1%, would insert into the cervix. I think I've seen about just 2 to 3 cases of cervical ectopics, basically, and I'm very sure there are many more because the prevalence will be due to risk factors, and the risk factors would also depend on where you are located, basically. As some risk factors are in more environments than they're in others, basically. And we'll talk about those risk factors shortly. The next, you can see some of this pregnancy is certain in the abdomen, basically. Yeah, you can see some of them inserting in the abdomen. You will check through. You will check through all of the, you will check through all of the parts of the pelvis. You're not going to see anything. You're not going to see anything at all. Then you now check the abdomen and then you see an ectopic pregnancy. I've seen a very huge one recently, not so recently, I think it was in 2024. So they're there with the placental tissues attached and adherent to intestinal and omental structures. And then we have scar ectopics, which happen when there is a previous uterine scar, probably from a previous cesarean section. Is that okay? And then when there is a later pregnancy, or maybe a myomectomy or something else. And then when there is a later pregnancy, the very funny pregnancy goes down to the scar and implants itself in it. So these are the places that ectopic pregnancies do occur. And like I said, the number of cases you see might strongly depend on the risk factors that you have, that what's it called, that you how prevalent or how concentrated the risk factors are in your area. And then I will mention some of the risk factors right now in a very fun way so that we can remember it. Another reason why we must know the risk factors is because in obtaining a good history, you are trying to tie the possibility of the symptom to an ectopic pregnancy when you can pick some few risk factors. And so what are these risk factors? First of all, for us to understand the risk factors, I'm going to bring out this lady here. This is Lady Shawarma. So her name is Lady what? Lady Shawarma. And then she is very fantastic. She, what's it called? She's a commercial sex worker, basically. And by virtue of the fact that she's a commercial sex worker, in this case, not saying that all commercial sex workers are prone to ectopic, but some certain risk factors that are present in them, basically, which I'm going to bring out, will be used to explain some of the risk factors in ectopic pregnancy. So she's a commercial sex worker. She loves life. She's rich, and she even has a gold orange juice. So, but then she had an ectopic pregnancy, and then we're now trying to find out what exactly are the risk factors. Apart from the fact that she's a commercial sex worker, that's MSP, multiple sexual partners, she also smokes and drinks a lot. She smokes and drinks what? A lot. And so, what are the risk factors that actually are present in this character, Lady Shawarma, that would allow her have ectopic pregnancies? Number one, the fact that she smokes. Smoking increases the chance of ectopic pregnancy. You know, she's a commercial sex worker. She's got to lighten the load on her head many times by some of these recreational activities. Though it's pleasurable in the instant, it's actually increasing the risk factor for ectopic pregnancy. Why? There is a relationship between smoking and how it affects the fimbriae, which are the what's it called? The combs that fan the what's it called? The the egg from the fallopian tubes and from the site of implantation into the ovaries. This is one of the reasons why it's mentioned, basically. And then, yeah, so altering epithelial integrity can now result in what's it called? Fimbrial dysmotility, difficulty for it to fan it properly into where it's supposed to implant. I trust you get that. Then also too, she does a lot of sexual work. And do you know how that affects her health? Basically, she's always consistently exposed to sexually transmitted infections. Sexually transmitted infections. And then another thing And so that sexually transmitted infection, PIL, and all this bacterial infection will lead to pelvic inflammatory disease, an ascending infection which will also damage the, what's it called, the pelvic organs, especially the ones associated with reproduction. This PID, as you can see, one of the complications is tubal damage. You find many of them having tube issues, tubal injuries. Chlamydia, for example, is known to do subtle subclinical damage to the tubes, sticking them together and not allowing free passage of a developing zygote freely into the endometrial cavity. So that's why PID is dangerous. But tubal damage is not only and this tubal damage definitely results directly also to increases the risk factors of our ectopic pregnancy. Tubal damage in itself does not only result from the um, injury from PID alone, surgical interventions can also cause tubal damage. So in short, PID increases the risk factors, tubal damage increases the risk factors. PID can cause tubal damage, so therefore the risk factors are increased. Another thing is that she has done a lot of abortions. A lot of abortions. Because of her work, she has gotten pregnant a lot, especially when she wasn't experienced in the first time. And so that resulted in multiple abortions. Increment in the abortions is proportional to the chances of ectopic pregnancies occurring. Please, 1 minute. Thank you very much. Um, yeah, I trust we are able to see me now. Very good. So now, in addition to this abortions, because she's trying to prevent more pregnancies, she now decides to use an IUCD, thinking that it will not allow her to get pregnant. But lo, IUCD increased the risk factor for ectopics. Also, too, all of these things that have been happening have been increasing the chances of endometrial injury, which increases the chances of ectopic pregnancy. And then she had an ectopic pregnancy before. That further increases the chances of an ectopic pregnancy. It further increases the chances of an ectopic pregnancy. And also, too, later in life, she repented, or maybe, yeah. And then she now has some things that reduce her fertility chances. Basically, a history of subfertility, or all of this history has culminated into a history of subfertility in her later life. She's beginning to regret it. She feels very bad. Ectopic pregnancy chance increases when she eventually gets pregnant. Then, because of the history of subfertility, she goes for IVF. After going for an IVF, so they put 7 embryos there. One went to the tube, the other went to the ovaries, the other went to the uterus, the other went to this place. So IVF increases the chances. Also, too, the old now because she's now trying to conceive when she's really serious and she's not able to conceive, basically, yeah, she now begins to, try to she's now getting older rather. Now, because she's getting older, advanced maternal age itself increases the chances of ectopic pregnancy. Then another condition which she develops later in life, endometriosis, also increases the chances. And then if peradventure she did not know all along there was a congenital uterine anomaly, it increases the chances. And then in probably one of those, and then also, so thank God for her life, she eventually gives birth. But after giving birth, she has placenta previa. They deal with that. Then in her next pregnancy, excuse me, she is pregnant again. So in her next pregnancy, it's now wrongly inserted. Placenta previa, a previous history of placenta previa is found to be strongly associated with ectopic pregnancy. So again, smoking, PID leading to tubal damage and other risk factors that cause tubal damages, abortions, IUCDs, endometrial injury, previous placenta previa, you know, congenital anomalies, advanced maternal age, IVF, prior ectopic pregnancy, history of subfertility, and endometriosis increase the chances of ectopic pregnancy. What are the key clinical presentations? So you spotted the risk factors. Then the woman first comes with a presenting complaint. What are those ones that should make you suspect that she has ectopic pregnancies? First of all, one thing I need you to know about this is you find it in a lot of, I think I've seen quite a lot, a good proportion of young women having this. So, but although advanced maternal age increases the risk factors, though, but then you come in, so don't try to block out young women because they're the ones that tend to have a lot of abortions, tubal damages, PID, a lot, basically. So don't block them out of your mind as not likely the uh, a prime risk factor in why she might be having low abdominal pain, bleeding, and hemodynamic stability, which are the symptoms of an ectopic gestation. So you find a young woman and sometimes an advanced age woman, she has three things, but primarily two first. The third we'll call later if the bleeding is profuse. You have low abdominal pain, bleeding per vaginum, and hemodynamic instability. Abdominal pain, bleeding per vaginum, hemodynamic instability. Lower abdominal pain, bleeding per vaginum, hemodynamic instability. So these are the things you will see and you will say, "Kai, this woman might have an ectopic gestation." If not, and what's it called? And then you've not done any other tests. You've seen the risk factors, all those risk factors we mentioned, and then you are now seeing that she's having low abdominal pain and she's bleeding. Okay, let's forget about hemodynamic instability. She's writhing in pain and she's bleeding. Mhm. And then you are now suspecting ectopic gestation. What are the things you can do? The ultrasound and something we call a serum beta HCG. Serum beta HCG is the pregnancy test, actually. That is the hormone that is usually checked for when we are or women are pregnant. We have two types, the qualitative and the quantitative beta HCG. Qualitative is that because it is present, it is pregnant, she is pregnant. Because it is absent, she's not pregnant. So we are either saying, is it present or is not present? We are not quantifying the values present. Nevertheless, in quantitative beta HCG, we are trying to quantify the values because we have been able to scientifically map out a trend or an association between a developing pregnancy, especially up to 8 weeks, and the beta HCG levels quantitatively. And this in itself can tell us if there is a normal pregnancy. Also, a behavior of this particular trend can also tell us if we ought to be suspecting an ectopic pregnancy. So therefore, a beta HCG quantitative should always be done as much as possible. Let's talk about beta HCG and a normal pregnancy. Beta HCG and a normal pregnancy. Beta HCG in a non-pregnant state is generally about less than 5 international units per liter. And if we have values greater than 5 international units, or some would say 5 milli international units per mils or per milliliter, if it is greater than that, in the right clinical context, it could indicate early trophoblastic activity. Trophoblast is that part of the developing gestation following some level of differentiation that begins to implant into the womb and eventually forms the placenta. It is the trophoblastic tissue that produces beta HCG. If you recall, we have a morula that becomes a blastocyst, which is a central mass of tissue surrounded by a ring and then a pool of fluid. Then that central mass of tissue will differentiate into trophoblast and embryoblast. Basically, that thing will differentiate into the central core will differentiate into embryoblast, while the outer ring or the outer parts will differentiate into trophoblast. The trophoblast will develop into syncytiotrophoblast and cytotrophoblast. The cytotrophoblast is the one that produces beta HCG. And earliest detectable beta HCG will be around 8 to 10 days post ovulation. So she ovulated, she fertilized. If there was a successful fertilization, you should be able to check it. You should be able to get a beta HCG. If you recall the previous lectures, you should be able to check the beta HCG that time, 8 to 10 days post ovulation. And the value should already have started reaching 50 to 100. But there's now one funny thing about this beta HCG. Are you following? So non-pregnant less than 5. Earliest detectable 8 to 10 days post ovulation. Then a very upward trend begins to happen. It accelerates. The rate of rise now begins to drastically increase up until about 6 to 7 weeks. And then after that 6 to 7 weeks, you now begin to watch a decline. This is how a normal pregnancy's beta HCG will behave. So we can't detect it in the non-pregnant state, or we detect a very small amount, less than 5. If you detect more than 5, suspect trophoblastic activity, either from a pregnancy or from a particular cell that has trophoblastic peculiarities, as you might see in a metastatic lesion of such kind of tissue origin, basically. So the earliest detectable time, 8 to 10 days. Then we now begin to rise up. We begin to go up. It is doubling every 48 hours, 1.5 to 2 days. Doubling, doubling. Then it gets to 7 weeks. Then it begins to peak and plateau and come down. That's what gives it the curvilinear rise. So if we now say, okay, can we now say this value is equal to this gestation? No, you can't say that, because the values are very, very variable for the same gestational age of two different women. So there is a wide inter-individual variability, and you should never interpret one value in isolation. Rather, monitor the trend. Monitor the trend. And so this is just a small table here that just shows us some of those sharp rises. These values vary. I can bring out another table again that literally will be showing you different figures, but we can see the trend, and usually it will be around this level. 3 weeks, 5 to 50. 4 weeks, it can still be as low as 5 to about 426. 5 weeks, then it begins to go up, but it's doubling every 48 hours, such that there is a drastic geometric increase. Is that okay? But then observe, 6 to 7 weeks, it peaks, or this one 7 to 8 weeks. So 6, 7 weeks, 8 weeks, kind of. It peaks, then it begins to drop, 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 and maintain a particular level. But the highest time will be in that particular place. And then in a non-pregnant state, it's usually under 5. So if we now see, let us suspect what might have happened to pregnancy development. Let's imagine what might have happened to pregnancy development just by looking for the beta HCG level. We can do that from different studies. We are able to map out where exactly we will be in pregnancy development just by looking at the beta HCG level. Usually, a gestational sac will be seen on transvaginal ultrasound many times at 5 weeks. Yolk sac will be seen about 5.5 weeks, and the embryo and cardiac activity will be seen around 6 weeks using the transvaginal ultrasound. Please, I want to encourage you, please share this channel to every of your colleagues. If you are finding it very interesting, let them join in the lectures, and then you can tell them to subscribe also to as well. Yes, please do. Tell them to subscribe. Is that okay? All right. Good. Sorry, 1 minute. Okay. So This is what we will begin to see on the ultrasound. The discriminatory zone, which is something we must know about, is that beta ECG level above which a normal intrauterine pregnancy should be reliably visible on transvaginal ultrasound. Meaning that if we see that beta HCG result and it is at this particular level, minimally at this particular level, it's at this particular level at a minimum. When you are doing a transvaginal, you should expect that you ought to see it. You ought to see a gestational sac and intrauterine pregnancy. So, and this can be said with such confidence, basically. And what are those values that have been mapped out? What are those values that have been talked about? Usually, they believe, or it is predicted rather, not they believe, a gestational sac is predicted to be visualized about half of the time at a beta ECG level of about 979 milli-international units per liter or milli-international units per milliliter or international units per liter. So about 1,000, we ought to, in 50% of cases, we can see it. If we don't see it, okay, we can say, okay, no problem. Let's come back in another time, maybe 48 hours. If it rises to about 2,421, you should see it in 90% of cases. So you see a result, beta ECG quantitative 2,421. You should tell the patient, ma'am, lie down on the couch. Let's check if there's a baby here. We should be able to see a baby here. This is very important because when we are talking of a wrongly implanted pregnancy, such beta HCG level will not correlate with what is being seen on the ultrasound. And then on 99% of the time, we will be seeing a gestational sac if the beta HCG level is about 3,994 or approximately 4,000. So therefore, we put all of these figures together and then we now publish a discriminatory zone of about 1,500 to 4,000, which can be used to aid the correlation of certain expected ultrasound findings. If your beta HCG is here, you are sure you should find the pregnancy inside the womb, in the womb, in the womb. So if your beta HCG is here and you don't find the pregnancy, you are supposed to be worried. Now, patients with beta HCGs greater than 3,500 mils definitely should have findings on ultrasound that demonstrates the location of pregnancy. Quite all right. And then, in fact, if we get to 7,200, you should even be seeing the yolk sac and the embryo. And then, if the HCG level gets to about 10,800, you should even see the embryo with a heartbeat. This is how certain our beta HCG level makes us when we are trying to correlate with an ultrasound finding. Because confusions might occur. A woman might have beta HCG levels of 800 and you are not seeing any intrauterine pregnancy. We may not it we what's it called? We may need to do a close monitoring rather than raise a false alarm. You understand? Basically. So it is when we are acquainted with these values that we will be able to now make proper clinical judgment. So therefore, this is another table summarizing what I just said. Less than 5, non-pregnant. 5 to 100, it's pregnant, but it's not visible. 979, 50% of cases should see it. 2,421, 90% of cases should see it. 3,005 to about 4,000, you almost always will see it. And then 5,000, 10,000 and above. Remember that 7 to 10,000 and above, that range, specifically around 7,200, you see the yolk sac. Greater than 10,000, fetal pole. Then surely 20,000 cardiac activity should be present. So now, if we now correlate or look at these findings and compare it with what we see in, excuse me, an ectopic gestation, we will see that apart from, before we even talk about the levels, we need to talk about the rise rate. Remember, I said there is an acceleration, a curvilinear growth. In ectopic gestation, the beta HCG will rise at a slower rate in ectopics than in normal intrauterine pregnancy. Remember I said beta HCG normally doubles every 48 hours. This one will not double every 48 hours. This one, in fact, will increase by less than 50%. Some texts say 39 to 49% is 33 to 49% is acceptable. So if less than that, such less than that kind of increase every 48 hours, then you should suspect either you have a non-viable intrauterine life or an extrauterine life, ectopic gestation. So the increase will be less than 50% every 48 hours, suggest ectopic pregnancy. So the beta HCG will slowly rise, plateau, and show a gradual or slower decline. Observe the pattern. So two things, the pattern. Then number two, the levels will be lower. They tend to have lower HCG levels compared to normal intrauterine pregnancies. And then last but not the least, which will be put into a summary, this trend of the slower rise and lower levels is more useful than single values in diagnosis. Don't just take one single value and say, oh, it's pronounced ectopic. So therefore, you will need to do not just one quantitative beta HCG, but the serial amount, and use that in the application of your assessment in ectopic gestation. But know this, and as we used to hear, know this and know peace. Nevertheless, ultrasound-based cutoffs strongly suggest ectopic pregnancy if beta HCG is in the discriminatory or above the discriminatory zone, 1,500, and yet you are not seeing any intrauterine pregnancy. Suspect it immediately. Immediately suspect it. Let's move. So this is what a 4 to 5 weeks TVS should look like. Yeah, we are seeing the gestational sac. Here we're seeing the yolk sac if it gets to about 5 weeks and some few days. This is the double decidual sac sign. This is another one again. And this is yeah, exactly. This is a small gestational sac within a background of a hyperechoic endometrium. Then look at a 6-week-old embryo on ultrasound. Just look at how it looks. At this period, you should be seeing, at this period, beta HCG should already be peaking. Should be peaking, peaking, peaking. Then if you take measurements for that, it begins to decline. So now that we've understood this, let's now talk about the ultrasound features that haven't done your beta HCG, or even before you do your beta HCG, the things that will make you suspect that you have an ectopic pregnancy so you can act immediately. Now, I group the signs into two, direct and indirect, or pathognomonic and non-pathognomonic. The direct signs are those signs that you directly, okay, repetition, sorry, but directly visualize. The things that you will see, that you will say, if I see this, no doubt about it, there is an ectopic pregnancy. I'll talk about what indirect signs mean. The first pathognomonic or direct sign that should make you make a diagnosis of ectopic pregnancy is that you are seeing either a gestational sac with or without a yolk sac, with or without an embryo, with or without cardiac activity outside the uterine cavity. Your diagnosis is not anything else but ectopic pregnancy. You look into the endometrial echoes, you have not even done beta HCG, it is empty. Then you are seeing something like this. See gestational sac, see yolk sac outside the endometrial echoes. Run and call the doctors. Oh, it's time for a brief surgery. That's very important. So sometimes you might see cardiac activity, sometimes the fetal echoes might be dead. I see quite a lot with cardiac activity. Fortunately, the pregnancies have to be terminated. So this is another ectopic again. This is the uterus here. This is the endometrium around here. This is the uterus. And then we are seeing an embryonic pole and a gestational sac. And you put pulse wave Doppler and you're seeing heartbeats. Please, ectopical. The next direct sign you will see is closely associated with what we have just talked about. And it talks about the perimeter surrounding that gestational sac. What you actually see is an echogenic, thick echogenic and highly vascular ring that surrounds such kind of a pregnancy. It is so thick, it looks like a donut, a round, not it's a circle donut. That is why it's called a bagel, because that's what the Americans will call a particular kind of donut, a bagel sign or a blob sign. So this is what we call the tubal ring sign. It is an echogenic ring that surrounds an unruptured ectopic pregnancy. It is actually just decidualization around the gestational sac. And it has a 95% positive predictive value of ectopic pregnancy. You see it, you see something like this, you've not even seen fetal echo inside, and you put color is vascular, please call the doctor. Then you now say, let me check the endometrium, nothing is there. Let me check the beta HCG is high. Call the doctor or act immediately, ask the doctor. And then because it is highly vascular, if you put color Doppler on it, it interacts so strongly. That's why we call it the ring of fire appearance. So again, this is a fetal pole with a surrounding gestational sac and this thick echogenic ring called the tubal ring sign just by the left ovary. Again, this is the uterine echoes around here and the endometrium around here. And then we are seeing it's thick, it's thicker than what you will see in normal corpus luteum. And then you will know that there is something inside this one that correlates with a pregnancy, tubal ring sign. Thick, hypervascular. Check it out, you see it. Because sometimes you might not see the fetal pole, but you see yolk sac inside, you see the gestational sac, based depending on the level of development. And then when it comes to vascularity, see how it lights up on power Doppler. And look at it again. Tubal ring sign. It's like a donut. You can't miss it. And see, there is even a small fetal pole inside of it. If you put the pulse wave Doppler, it might interact, it might not interact. Is that okay? And then we're seeing this outside the uterine echoes. Is that okay? So always put a color Doppler on it because it is highly vascular. It is always vascular. I mean, it is that crown that is bringing blood to the baby for development. So you expect quite a lot of blood inside, low resistive flow inside of it. Those are the two pathognomonic signs. But then we also have indirect signs, and these ones I have seen a lot. You won't see that gestational sac immediately. You won't see the tubal ring sign immediately. You will see some of these signs. They will not make you definitively diagnose an ectopic pregnancy. Nevertheless, when you see them, increase your index of suspicion, especially when you have associated symptoms of ectopic pregnancy, plus a pregnancy test, if done. So they occur directly with the direct signs, but they don't directly visualize or definitively suggest ectopic pregnancy. They can be associated with other conditions. So the summary is that individually, it is inconclusive if you use it in isolation, but cumulatively, we can use it to build a case. Cumulatively with what? With the risk factors, with the symptoms, with all other ultrasound features, and with the serum beta HCG. The first indirect sign is an empty uterus. Obviously, you can't use an empty uterus in isolation to diagnose ectopic pregnancy. The best case scenario, an empty uterus can also be in a normal pelvic sonogram. So, but nevertheless, you will have an empty uterus in ectopic pregnancy, except in another particular very rare condition called heterotopic gestation, where you have, it's rare. I think I've only seen one. You find a developing gestational sac, plus or minus a tubal ring sign, outside the womb, and another one inside the endometrial cavity or inside the endometrial echoes. So look at this picture here. This uterus, the endometrial sac, the endometrial echoes have nothing to show, but just hyperechoic. And you can see the tubal ring sign here and the fetal pole just around it. So this is the heterotopic gestation I was talking about. So you can see it's inside the womb and outside the womb. This is an heterotopic gestation. You could see it one day. So let it be something you're thinking about. Now, when it comes to the endometrial cavity, the empty endometrial cavity, we can further characterize it into how it will look, because there are specific patterns, if you look very closely, that are usually associated with ectopic gestations. Now, these are not signs that increase the sensitivity to ectopic gestation. Rather, they are things that if you see them, yeah, they are usually what you will find with an ectopic gestation. That's what we call specificity. Nevertheless, you can find them in other conditions. One way the endometrium always looks in ectopic gestation, because the reason I'm saying is a lot of people have the idea that, especially already practicing sonologists and sonographers, that it's supposed to be hyperechoic. Maybe not in all cases, basically. So it's very important you know which endometrial echo pattern is usually associated with ectopic pregnancies. The most specific endometrial finding is the trilaminar pattern, which occurs in 94% of cases, according to some studies, and 85.2 to 100% of cases in some others. Then we can now double down to another one where we have it being hyperechoic, like I talked about, and homogeneous. Then the next one is that it could be heterogeneous and hyperechoic. So trilaminar pattern, three-line sign, homogeneous hyperechoic, heterogeneous hyperechoic. Take note of this. And it's very important I define what we call ariastellar reaction. It is a pathological diagnosis that can appear as a hyperechoic endometrium. Ariastellar reaction is a pathological condition or diagnosis that can present as a hyperechoic endometrium. Is that okay? Take note of that. So what is it? It's a cellular reaction involving endometrial glandular cells following hormonal stimulation of chronic tissue, of chorionic tissue rather. So the cells react, the endometrial glandular cells react following the stimulation by hormones on the from chorionic tissue. It presents as a hyperechoic endometrial plate, although it is not all that would be hyperechoic endometrial plates. That's why I said it, because sometimes we say hyperechoic endometrium and then we're calling it Ariastellar's reaction. Just say that the endometrial cavity is empty and appears hyperechoic, possible Ariastellar's reaction. Is that okay? That's an ideal way to put it for the purpose of excellence. So let's look at that trilaminar. So you can see it, three-line sign. One line here, another line here, another nice line here. Is that okay? And then we have this in most cases. I see this a lot. I haven't understood that everything will not be hyperechoic sometimes. Then the next one is heterogeneous hyperechoic endometrium. You can see it's heterogeneous, but to a good extent, largely hyperechoic. Also seen. And this one, homogeneous hyperechoic. Is that okay? All right. Then the next thing you can see, the next indirect sign associated with the uterine echo is what we call a pseudogestational sac. I've seen this many times. You will think it's a gestational sac, but it's not actually a gestational sac. It's a small amount of intrauterine fluid in a setting of positive pregnancy test and abdominal pain. It is not a gestational sac. It's just fluid inside the endometrial cavity. And look at how it looks. You can see it looks pretty unusual and very different from a gestational sac. That's why it's called the pseudo gestational sac. And what are some of the things that make it stand out? First of all, is the irregularly shaped nature of this sac and its pointed edges, like a beak, which is why it's called beaking. And it is usually centrally positioned within the endometrial cavity. It might contain clear fluid, and then also to it might contain debris. Is that okay? It is also, it may also to, it's what it will do is, it will, unlike normal pregnancy which implants in the endometrial echo, this one will displace the anterior and posterior endometrial surface, although you will not see this. Okay, well, you can have a, you can see this kind of on the scan, but you won't open the womb to check it, but you will see it splitting open the endometrial cavity. and then it is surrounded by a thick decidual layer. May be surrounded by a thick decidual layer. So these are pseudogestational sacs. So remember, they contain clear fluid or debris, big shaped. So look at this clear fluid. I think this is what's it called, the baby? No. But first of all, look at the big shape. Then it contains fluid with internal echoes, pseudogestational sac. This one also too, containing internal echoes, pseudogestational sac. It will there will be symmetrical thickening of the surrounding endometrial echoes, except if probably there is a pathology with the of the myometrial echoes rather, except if there is a pathology, there will be what's it called, a similar thickness, surrounding similar thickness of the myometrial echoes to the gestational to the pseudogestational sac, except if there is an issue, an underlying pathology with the myometrial echoes, especially those pathologies that make one side of the myometrium thicker than the other. And a very classical example is adenomyosis. So this is the pseudogestational sac again. Remember the beacon, clear fluid again. So that is pseudogestational sac, but compare it to a true gestational sac. That's how it looks. So in summary, gestational sac is smooth, round, or oval. Pseudosac is irregular. We also call it pseudosac. In central part of the uterus, you find the gestational sac. The pseudosac can also be found in other locations. Although the gestational sac can also be found, yeah, it can also be found in other locations. But also too, note that in the earlier part of gestation, the gestational sac can be found centrally within the fundal segment of the endometrial cavity, because of implantation around that area. Also, too, gestational sac is beneath the endometrium, while pseudosac is within the endometrium. Double decidual sac sign may not always be present, but sharp edges with possible debris in the lumen is what we will see for the ultrasound features of a pseudosac. Now, another thing is what we call the decidual cast, still within the endometrium. This one is the presence of the amount of relatively echogenic material in the uterine cavity in the context of ectopic pregnancy. Then let's now talk about indirect signs relating to the what's it called, to the peritoneum, specifically the peritoneum. Now, the major one that we should think about, so this is peritoneum. The major one that we should think about is fluid in the pouch of Douglas, or free fluid within the peritoneal cavity. So you could have free fluid behind the uterine echoes, but not only there, which is the part of Douglas. You can also have it in the paracolic gutters, and then you will have it just at the tail end of the liver. That's the hepatorenal recess. Is that okay? Or Morrison's pouch. So you have fluid there. And many times this fluid is blood. And so because it is blood, it may not always be free fluid. As a matter of fact, it will be complex fluid with internal echoes. Suspect complex fluid with internal echoes in the pouch of Douglas. It might suggest an ectopic pregnancy, slow leaking or ruptured, or anyone. Then look at clear fluid in the Morrison's pouch just beneath the liver. You can see that inferior to the hepatic echoes. Tells you about the possibility of the ectopic pregnancy. Indirect alone, you won't be able to use it to diagnose because this can be present in ascites. So hemoperitoneum, which is blood, the fluid now is blood in the endometrial cavity. So you will see this complex fluid in the pouch of Douglas, sometimes extending to the adnexia, left and right. Suspect ectopic pregnancy, because sometimes the internal echoes will be so echogenic, it will not even allow you to appreciate the echogenic tubal ring sign. That's why I said, when you see it, let your index of suspicion be high. So look at it again, complex fluid, complex fluid. Are you seeing here that we have not even seen any form of ectopic pregnancy, but just complex fluid behind the womb? In the context of symptoms, ectopic pregnancy suspected. Oh, yes. Look at this other heterogeneous collection. Look at it. Before we even start looking out for it, place would also be tender. Before we start looking out for it, complex fluid. Indirect signs. Other indirect signs, the ones in the adnexia. You could have complex extra-adnexial masses. It is actually going to be a tubal ectopic gestation that does not give that characteristic tubal rig sign. A matched up mass of the ectopic with so many things, just complex extra-adnexial masses, mass or cyst can make you raise an index of suspicion. Then also too, and intra-adnexial cystic mass, like a corpus luteum, could demonstrate ring of pie appearance, especially in the context of an empty endometrial cavity, can let you know that you might be dealing with an ectopic gestation. Then also too, a simple adnexial cyst help you, can just raise your index of suspicion. You can have a simple adnexial cyst in many other things apart from ectopic. So therefore, you won't be saying, ah, I saw a simple adnexial cyst, ectopic. No, 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 no. Look at it in the context of symptoms, risk factors, and laboratory investigations. And also to a solid hyperechoic mass, non-specific, but at least just let it raise your index of suspicion and investigate well. So in summary, we have a live or dead um, extrauterine gestation. We have a live or dead extrauterine gestation. Basically, very, very what's it called? Important. Okay. Someone said PUL. Please, can you abbreviate in the comment section? Can you abbreviate what PUL means so that I'll see it and then I'll just add it to the lecture? But this is fantastic. Yes, exactly. So, dead or alive extrauterine gestation, beta HCG greater than 1,500 with no visible intrauterine gestation, suspect ectopic pregnancy. Tubal ring sign, suspect. Complicated or clear POD fluid, suspect. Clinical history of low abdominal pain and bleeding in a young woman, suspect. Then, the lab serum PT is positive. All scream ectopic. Never forget. Thank you so much for listening. This was a shorter lecture than the others, basically, and I trust it was worth it. Before we go, let us just take some pop quizzes, basically. This that has to do with general ultrasound, basically. Which of the following statements is correct? Lower frequencies are easily attenuated. Higher frequencies are easily attenuated. This is talking about the frequencies emitted by the ultrasound probes. The lower the frequency of the probe, the lesser the depth. The lower frequency probes will be most preferred in evaluating a small back lipoma. High frequency probes are not recommended in an ocular scan. So the answer here is, what's it called? High frequencies are easily attenuated. If what happens with high frequency sound is it doesn't travel far, so therefore it will not be able to do tasks that require high penetration. There are lectures in foundational ultrasound that I have, basically, on groups available. If you're interested, paid groups available. If you're interested, you can reach out. So, but and then also too, some of them will be dispensed freely, but that will be much later. But if you want to see foundational lectures, you can always reach out. High frequency cover lesser distance than lower frequencies. Yeah. So let's now do a case scenario. 12th of July 2024 is the last menstrual period of this woman, and she's bleeding PV, lower abdominal cramp, serum PT is positive. Your ultrasound findings shows enlarged uterine echoes with a centrally located gestational sac containing a fetal pole with visible cardiac activity and a yolk sac. Also, a small-sized irregular or anechoic collection with internal echogenic debris in between the fundal pole of the gestational sac and the decidualized endometrium. What's the diagnosis? Threatened abortion. Why? Visible cardiac activity. So now, in the next webinar, we'll talk about the miscarriages. That's in May. Which so you can know how to assess a miscarriage. Which of the following does not impact negatively on the prognosis of a threatened miscarriage? Fetal bradycardia, amnon not visualized, MSD and CRL difference less than 5 mm, large subchorionic hematoma, small MSD for age. That should be that should be B. Following are poor prognostic indicators of threatened abortions. Fetal bradycardia, small mean sac diameter for age, calcified yolk sacs, mean sac diameter minus CRL less than 5 mm, large subchorionic hematoma, expanded amnion sign, absence to poor decidual reaction, not amnion not visualized, expanded amnion sign, or yes, exactly. Yeah. So question 4, the woman has with a previously established pregnancy, 12 weeks, 6 days, shows a visible fetal pole with no detectable cardiac activity. I just decided to put miscarriage things here, so just to refresh our memories. Mhm. And then we now have a fetal pole with no detectable cardiac activity showing 9 weeks. No eventful clinical history. The assessment will be a missed miscarriage. Hmm? So, which of the following is not true on what's it called? On transabdominal ultrasound, fetal heart rate must be visible with a CRL of greater than 7 mm. Yeah, must. On a transabdominal ultrasound, the visible embryo to be visualized with an MSD of 25 mm. I believe is an above, yeah. A yolk sac usually appears with an MSD of 20 mm, yeah. CRL greater than 7 mm without fetal heart rate missed abortion, yeah. CRL estimates weight, absolutely not. Thank you very, very, very much for this presentation. Please, I want to encourage you. We're building a very large community. If you have not subscribed, please click the subscribe button now before you exit. Is that okay? Then also too, you can scan the QR code to join the link tree. I hope this lecture was pretty beneficial for you. The downloads are very much available and you can always get them at your best time as it will be left on the page. It will be left on the page. Is that okay? So please subscribe, 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 and share this channel. Medical students, share them. People on radiology posting, please do share them. Classrooms, share them. Please, I encourage you. It encourages us to give more value. Thank you very much for the opportunity. Let's have a beautiful evening. Cheers. And then, okay, before we go, before we have a beautiful evening, please, you can just also let me know in the comment section how the lectures were. Someone has already said very insightful. Thank you very much. Thank you so much. Thank you so much. Well done. Let's have a lovely day, everybody. Mhm. Thank you. Someone said interesting class. Thank you very much. Thank you. Well done. Okay. Bye, everyone. Bye-bye.
Bye.
Thank
Thank
you.
you.
Thank you so much, Goody Brand. Thank you. Thank you very much. Thank you, everybody.